And so we're going to start with our first speaker today. So Professor Erin Nelson. She's joining us from the University of Alberta, Faculty of Law. She's a professor there, and she's going to present access to abortion care in Alberta.
Thank you very much, Karen, for the introduction, and thank you to the organizers for inviting me here. What I'm going to talk about today is access to abortion in Alberta specifically. This is an area of interest that I've had for a long time, and I've just recently been involved with some colleagues in Calgary doing some really sort of detailed looks at what is happening from an access standpoint. And so I'm excited to talk about this issue here with this group today. So as we've already heard today, the law in general is not the impediment to abortion access in Canada, and that's the same in Alberta. Abortion is considered to be a medically necessary service, and it's covered by Canada's public healthcare insurance plans in every jurisdiction in Canada. And that now even includes more broader access in New Brunswick, as we also heard this morning with the change in the law there. So coverage is available generally for both hospital and clinic abortion services. But in spite of the reasonably stable and favorable legal situation that we have, we know that many Canadians face difficulties gaining access to abortion. So the question, is to what extent is that a problem, and also to start to explore why that remains a problem. One key barrier to access is geographic. It is really difficult if you don't live in a major center in Canada to find available providers. Another issue that's linked to geography is cost. So if you have to travel to obtain abortion services, there are usually costs associated with that travel. We also know that provider conscientious objection can be a barrier, but we don't know the extent to which that is a barrier. So we know in general terms about the existence of these barriers, but we don't really have a lot of information about the details, about the specific impediments to access and the magnitude of those impediments. We do have some Canada-wide data on abortion, but we know that it's incomplete. The Canadian Institute of Health Information collects this data, but only hospitals are required to report. Clinic reporting is voluntary, and so we know that the data tend to be sort of an underestimate of abortion rates, particularly because most abortions now are done in clinics rather than in hospitals. And indeed, the first, we've also talked about, we've heard a bit today about mifepristone and its approval in Canada and its potential for really improving the access problem. And really interestingly, the first of the two studies that I'm going to talk about this afternoon was spurred on by a story that a colleague of mine relayed at an Alberta Medical Association meeting in 2022. She had prescribed mifepristone to a patient. She was in Calgary. The patient was in Calgary. That's the biggest city in Alberta, for those of you who might not know that. And the patient had to call 8 pharmacies before she found a pharmacy that had mifepristone in stock. So that was a bit of a shock, both I think to the physician who prescribed the medication and to those of us who heard that story. So we know from studies in the past that clinics and providers tend to be concentrated in large urban centers. Wendy Norman did a study in 2012, a survey showing that most clinics are located only in those larger areas, except in British Columbia and Quebec, where there has been some policy attention to ensuring a more equitable distribution of facilities within the province. So she found that overall about 33% of facilities were in non-census metropolitan areas, so smaller centers, and 48% of females of childbearing age lived outside of a census metropolitan area. And another study reported in 2013, who one of the co-authors of that study is right here beside me, reported really lengthy travel times for many Canadians, including especially lengthy travel times for First Nations and Métis women. They were almost 3 times as likely as other participants to have traveled over 100 kilometers to access abortion services. So it seems that the access issues can be particularly magnified for Indigenous women. Both of those studies that I just mentioned were done before mifepristone, so they're largely related to surgical abortion. And as I said, early data about mifepristone does show that it has the real potential to improve access. Again, another study by Wendy Norman showed a really significant increase in provider numbers between 2012, a survey showed 62 medical abortion providers. A study in 2019, so 7 years later, showed that that number had increased to 388. So that's a really significant increase. Most of those respondents in the 2019 study were in primary care practice, and they provided just over 70% of the reported first trimester medical abortions. And again, another improvement in access is shown by the number of medical abortions. In 2012, roughly 3.6% of abortions were medical abortions, and that was, of course, off-label prescribing of methotrexate. Mifepristone hadn't yet been approved. In 2019, almost 28% of all reported abortions were first trimester medical abortions. I'm trying to talk fast, so I'm just gonna blend all the words together. So what about access to abortion in Alberta? What's the sort of current picture? We have all this background, but can we maybe get a bit more fine-grained in terms of the knowledge about that particular issue? And I think before I even show you any of these images and talk about this a bit more specifically, I want to mention that it took roughly 18 months for my co-author who analyzed the data to get the data from Alberta Health Services. It was an unbelievable journey, I don't know how else to describe it, of having to repeatedly find different people to ask within Alberta Health Services just to get access to this data. So I don't know how to explain that. It's dismaying. Alberta Health Services is not the owner of this information. In my view, this information belongs to Albertans, and it shouldn't be this difficult to be able to obtain it. So what did the data show us? Once we got it, what did we learn? One thing we learned is that surgical abortion rates have been falling in Alberta. And because most abortions are still surgical, the abortion rate overall has also been falling, and that's consistent, I think, with most of the country. But what I think also we really learned here was how challenging access remains in Alberta. So I don't know how readable the legend in the center is. My technical skills were just not up to the task of making that picture big enough. But I don't think you even really need to see the legend itself. The darker the color, the darker the part of the province, the longer the driving time is. And the darkest green on that slide is over 4 hours of driving time. So you can see in 2012 and in 2022, the image hasn't really changed a huge amount, except to say that in the northern part of the province, if anything, things have gotten a bit worse. So that's surgical abortion median driving times. This is medical abortion median driving times, which is interesting, certainly a different picture. The first image is from 2017, 2018, and the second from 2022. So you can see after mifepristone became available that driving times dropped substantially in most, maybe all. I think most with an exception of that little part on the northeast border. Those driving times dropped substantially. This, I think, is an interesting picture to just show you how little change there has been in general in terms of the median travel time to abortion care in the province in the last 10 years. So the purple line kind of in the middle is overall driving time. Pink is first trimester surgical abortion. Orange is second trimester surgical. yellow, the yellow line is medical abortion. So that one we do see a bit of a change, and blue is abortions by way of induction of labor. So the data are not, I would say, reassuring from the standpoint of access improvements for the most part. We also saw really, I guess, in some contexts, a worsening picture as far as the access issue is concerned. So we have a small subset of facilities and providers providing abortion, and that small subset of 3, there are 2 facilities in Calgary and 1 in Edmonton, provided 99.7% of surgical abortions in 2022. Travel distance is not surprisingly longer for those living outside of Calgary and Edmonton. There's a mismatch between demand and provision. And one thing I wanted to note specifically is that there's a subzone in the northeast corner of the province, which had the highest rates of both medical and surgical abortions in terms of patient homes, and recorded no provision of either surgical or medical abortion. So we have what my co-author refers to as abortion deserts in Alberta, or at least one really significant one. I didn't even bother reproducing the legend for this one, because the white areas of the province mean that there's no facility location. So I just thought that was telling in and of itself. The image on the left, of course, being facilities for surgical abortion, and on the right for medical abortion. All right. So what about medical abortion specifically? We've heard really positive things in some contexts about improvements in access that are at least possible in theory based on medical abortion being available. And an analysis of the use and safety of abortion services in Ontario that was published in 2022 shows a really big increase between the initial approval of mifepristone, as many of you know, was given with significant restrictions that made access very difficult. Once those restrictions were removed, we saw the proportion of medical abortions increase substantially from 8.3% to 31.4%. I know I don't have a lot of time. I have a lot of information that I was hoping to get to. So some of this I think we'll just get to in the questions, but similar numbers in terms of significant proportions of abortion being medical abortions come from the Canadian Institute of Health Information. This is not broken down by province. This is based on reporting from, I think, 5, maybe 6 provinces, showing that substantial numbers, up to maybe almost 40% of abortions were medical in 2022. What about in Alberta? Not that good a picture. 13.8% in 2022 and 20.3%, which is an estimate for the year based on the first 6 months, which is the data we have, are medical abortions. The last thing I wanted to note, we're doing a second study. So the first study was just getting this data from Alberta Health Services and trying to sort of figure out what we could about where people are able to access services. The second one was my co-author and her team contacted the individual pharmacies in the province. They tried to contact every pharmacy. They were able to contact almost all of them to ask. They were basically proceeded on the way of a mystery caller approach and said, I'm a physician or I'm a staff member in a medical office. I'm looking to prescribe mifepristone for a patient of mine. If they were to come to your pharmacy, do you have it in stock today? And the numbers are dismaying, to say the least. 12.9% of pharmacies said yes. Of the rest, many offered to order mifepristone in. Most of the time, if the pharmacy was in a larger center, the time frame was around 48 hours that it would take for the drug to be provided. But for smaller centers or more remote areas, some of the delivery times were up to 10 days. And so for a time-sensitive service like medical abortion, you can imagine that that's not particularly effective. Okay, I'm almost out of time. I'm happy to answer questions about any of the rest of this, but I just wanted to say a quick thank you for the research support to the CIHR Women and Gender Equity and National Women's Health Research Initiative Hubs program. And I will leave it at that and happily answer questions about
that. Okay. Thank you very much, Professor Nelson. So we'll take questions at the end. We're moving now to Eleanor McGrath, a doctoral student in political science at the University of Waterloo and Shirk Doctoral Fellowship. And they will present Doing Harm, a Century of Missing Data and Policy Inaction on Maternal Mortality in Canada.
Hi, everybody. Sorry, I hate microphones. I am so thrilled to be here joining with you today and sharing the very, very, very beginnings of my dissertation work in this presentation, which I called Doing Harm, a Century of Missing Data and Policy Inaction on Maternal Mortality in Canada. I'm a PhD candidate in political science at the University of Waterloo. As I said, and I will continue to emphasize throughout my presentation, this is still the very beginnings of my work. I actually arrived in Ottawa this past Sunday so that I could spend the first 3 days this week at the archives. So some of what I'm presenting today is very fresh out of the archives, still has some dust sitting on it. And my project basically is focusing on why has Canada not implemented a more robust data collection and investigation into maternal mortality and severe maternal morbidity. I'll get into some of the context as we go, but basically we don't really have any sort of national data that is accurate and useful for improvements in care. Today, I'm going to present you with a bit of context and then focus on some of the more interesting key events that I've uncovered so far, noting that there's probably gaps because it's still the beginning. I am not going to have many answers for you today, so please get comfortable with the loose ends that are going to be at the end of my presentation. Okay. Some key terms, just so we're on the same page. Noting that these definitions are, as many things in our field, are contested and not fully agreed upon. But in general, maternal mortality is a death while pregnant or up to 42 days after a birth or termination of the pregnancy. And the cousin terminology here is the severe maternal morbidity, which is a set of unexpected pregnancy-associated maternal outcomes resulting in severe illness, prolonged hospitalization, long-term disability, or high case fatality, also called near misses. Okay, so today, I'm gonna do things sort of backwards. I'm gonna give you what things look like today, and then we're gonna take the time machine. So today, Canada's existing data on maternal mortality is so unreliable that the World Health Organization increases our estimates by 60%. The SOGC, the Society of Obstetricians and Gynecologists of Canada, is working on making a tracking and surveillance system happen at a national level. They are encountering some challenges, which is part of what has motivated my research. Data sharing between and across provinces is difficult. There's all sorts of, privacy legislation and federalism. I'm a political scientist, right? We love to blame everything on federalism. But it is possible. And we see that with other conditions where we do have really good national data sets. If we're looking to who's actually doing this and doing it well, generally speaking, the United Kingdom is regarded as like the model, the standard that we should be looking towards. They have a very robust system. And we, the group at SOGC that is working on this, they are working in counterpart with folks at the UK who know how this should look when it's done properly. And we have other national health projects that we can learn from, right? So not limited to just the reproductive sphere. Okay, so, but when we talk about maternal mortality, generally speaking, people are like, but that doesn't happen here. I am here to be the dark cloud in your life and burst your bubble. Every year there is about 6,000 or more severe maternal outcomes. So that's the near miss, plus an additional 30 to 84. Again, we don't have good data. 30 to 84 is kind of a wild range, but there you go. Maternal deaths in Canada each year. With no reliable data on the prevalence and no investigation into the causes or ways to improve outcomes, Canada cannot make progress to reduce those impacts. We also suspect, but again, no data, that maternal mortality and severe maternal morbidity affect Black, Indigenous, and other people of color and other marginalized folks disproportionately. We suspect this because of data from other countries that actually do collect that data. But again, in the Canadian context, we don't know yet. Okay, so a good DeLorean for anybody who's a fan. We're going to step back in time now. So now we're getting into the archival work that I have been doing. There we go. Okay, so we're going to start in the 1920s with the Conference on the Medical Services in Canada in 1924. So Dr. Helen McMurky, I'm not sure. She was then the Director of Child Welfare in the Department of Public Health. And she noted in this presentation to representatives from academia, departments of health, provincial physicians' colleges, and medical associations that the inaccurate and incomplete data on maternal mortality prevents policymakers and care providers from learning from adverse outcomes and improving care. 100 years ago, and here we are. Okay, so then another doctor at the same conference, Dr. Jost, asked, like, should a comprehensive investigation be made into maternal mortality in Canada? And if so, by whom? Okay, well, that was basically the end of that discussion. So then she was commissioned, though, to do this study into maternal mortality in Canada. And so she wrote this big report. She collected data from Dominion Day in 1925, when's the last time someone heard that term? So July 1st, for anyone who's wondering. From Dominion Day 1925 to Dominion Day 1926, she collects data across the country as, again, the chief of the Division of Child Welfare. I'll come back to that point at the end of my presentation. And publishes this report, which I managed to get my hands on from the library at McMaster. They absolutely should not have sent it to me. It is fragile, but they did. So anyway, she published her report in 1928. And then we see someone that maybe you have heard of before, Agnes MacPhail, who was a member of Parliament. She is like frustrated about this. She reads this report and she's like, this is terrible. We should do something about this. And so she kind of keeps following up in the House of Commons, and she's frustrated because the Prime Minister keeps like skirting responsibility, being like, it's the provinces, they need to do something. Again, federalism. And so she says, I do not care whether it is the provinces or the Dominion that do it, but it is something we cannot remain quiet about. It is rather remarkable that previous to this session, this great drain on our national life, the death of mothers, was mentioned in the House of Commons only once. It is not a subject the Commons have ever interested themselves in, and it is a subject that should be of interest to everybody who has the welfare of Canada at heart. I hope the minister will be prepared next session to do something definite and far-reaching in this manner. She's more optimistic than I am. So then we had like another person who suggested that, like, okay, well, maybe the Canadian Medical Association could do this. So we have some examples of some national advocacy in this time period, and also some ideas of how it could happen logistically, financially. There was talk about like, okay, the public purse, we could pay for this. That first report was paid for by the government, right? So there was some ideas here that then didn't happen. It's going to be a theme in my presentation. Spoilers. Okay. So the Canadian Medical Association, again, in the 1930s, suggests that maybe local associations should dedicate one meeting each year to preventative obstetrics. But in this document I found, it said, but the response was poor and overwhelmingly negative. All right. So then this guy, so this is a member of Parliament Maloney, on the 3rd of March in 1930, says, the government must remember that the citizen of Canada is the property of the state. I can't say that without laughing. And it is the duty of this government to protect the citizen in every possible way. And he was again talking about this idea of preventative obstetrics, maternal mortality. Maybe we should do something about it. Then in 1935, Dr. McMurky retires, and I presume goes off to some nice island. And so then there's a bit of a panic, right? So now who's going to do this work, right? Our key person is retiring. What's going to happen? And so then the government decides, okay, we're going to give this work to the Canadian Council on Child and Family Welfare. And then this guy, another member of Parliament Blair, says, and this is like telling of all of the biases at play here, says, I do not think the work should be taken out of the hands of the Department of Health. Surely, if this is a medical department, a doctor, and not some person who is merely a graduate of Queen's University should be in charge of the situation. I apologize to anybody from Queen's in the room. Apparently he didn't like Queen's. I don't know. Okay. Then in the 1940s, I think there was some other things happening in the world. And so things got put on hold. I haven't so far uncovered anything about maternal mortality in the 1940s. We were maybe busy. Okay, in the 1950s, then things get interesting. So we've talked a little bit about like, okay, the government could be doing this, could be funding it, but we're not going to. Okay, Canadian Medical Association wants something to be done, but they don't. And so now we get into this idea of confidentiality, because whenever you're talking about health data, you have to talk about confidentiality and how it's passing across borders and to different people and different organizations. So the World Health Organization has this conference about medical statistics. And so this report about this conference said confidentiality of medical information was also discussed, but the conference agreed that it was not yet possible to make a specific recommendation about the transmission of medical information. Later on, though, later on in that report, you have someone who talks about how in order to be accurate, the cause of death has to be certified by a physician. And in order to be truthful, the physician had in certain countries to be protected against legal and psychological consequences of his certification of certain causes. So you hear the like sort of echoes of liability kind of creeping up in the back. In the 1960s, this is a doctor who is writing about maternal mortality in Ontario specifically. It says, in order to improve the maternal mortality figures, it is of prime importance to have accurate reporting of all cases. Who would have thought? Only if exact data are available and if the necessary authority exists, will it be possible to study all the details of the cases and circumstances under which such a death occurred. And then they're talking about setting up these maternal welfare committees in each of the provinces to be able to track and take care of this. And so they say, you know, this one thing that we do know is wherever a maternal welfare committee is set up, certain events seem to follow inevitably. First, there is a reawakening of interest in obstetrical care, and then an increase in the rate of consultations, and finally, the lowering of maternal mortality. Basically, if we actually care about it, then we can fix it. That's it for my time machine for now. That's like the loose ends of where I've landed at the moment. So some very, very preliminary themes that are coming out, and hopefully you heard them as well. Maternal health is only important as it relates to the child. So nobody in those decades was really talking about like maternal mortality as being important because like she's a human being and maybe she shouldn't die. It was really in regards to like her childbearing capacity, her eventual motherhood. That was how it was always framed. There's this persistent acknowledgement that there are ways this problem could be addressed logistically, financially, and yet no consistent action and no concerted effort to make it happen. So the idea that we're sitting here in 2024 going like, oh my God, we still haven't done it. Well, we knew there were ways and there still are. And then this conflict and prioritization of privacy and confidentiality versus full information to make health and healthcare improvements, I think is really striking. And that's a bit where the title of my presentation came from. At what point is protecting privacy and confidentiality actually doing harm? This little gem here was that I don't know if it's legible in the back of the room, but just thought that this was great. It was, remember our motto, for home and country. nobody can do for home and country what the mother can. And the best way to get a mother to take care of herself is by telling her that she must do it for the sake of her husband and the children. She thinks they are more important than she is, but are they? All right, I have 1 minute left. So my last pitch here is, why do we actually need a national system? So coming back to, again, the motivations for this, some provinces are too small to be able to report on maternal mortality. Again, if you're thinking about Prince Edward Island, they might only have one mortality every couple of years, which is a good thing. But then from a statistical perspective, you can't report on that because of confidentiality and things. Yeah, I saw it. Okay. Yeah. Oh, on there. Oh, my bad. Oh, thank you. Sorry, I've got two screens going. It doesn't work well. Maternal mortality is often used as an international benchmark for the quality of healthcare systems. So if Canada wants to be able to state its place in the world, this is something we should care about. And then combining data across all the provinces provides more opportunities for actual improvement and learning, because then if you're in PEI, you can learn from all the cases that are happening across the country. Thank you and stay tuned.
Thank you very much. Okay, we'll move on to our next speaker. I'll remind, thank you for the first two speakers for being very time sensitive. For those at the end of the table here, I'll remind you to keep your attention periodically to our organizer table, and they will give you time cues. Our next speaker, Dr. Karen Lawford, Aboriginal midwife, center scientist at the McMaster Midwifery Research Center, an associate professor in the Department of Obstetrics, Gynecology, Midwifery Education Program at McMaster University, will present to us Repairing the Loss of Rights of Indigenous Peoples through Indigenous Midwifery.
Alrighty. I don't know. Oh, there we go. Let me just change this. Oh, yeah, look at that. Okay. Hi. So I just put this title because I'm trying to be nice, but the word loss should be theft. So this is the take home. And if you don't know Good You Cook, but you have the pleasure of, please, she's a Mohawk midwife, such a good person, and very kind. And I really do believe this to be true. I do have her permission to share this quote, and I'm going to turn it into a sticker. Indigenous midwifery is an Indigenous community longing for itself. It's actually quite hard for me to hear all the conversation today because the backdrop of it always is whiteness. And I assure you that's not true in real life. So a little bit about me. This is a curious cat because I think people always wonder, how did this person get into this position? I don't know either. Many degrees. So I'm Anishinaabe from Treaty 3. On the picture there is me filleting a red suckerfish. It's a special fish for my people. In the right hand, I'm swimming in the Salish Sea, trying to become a mermaid with my friend Nicole. It didn't work yet. And on the picture below, I'm in Prince Albert on about 8 feet of ice, and it was cold. Holly knows. Anyone from Saskatchewan besides? There we go. You know. So this is where my family's from. Sorry, it's a bit white out here, but it's a fly-in community that you drive up to Red Lake, which is a gold mine. Anyone here from okay? No, but you know where it is. Awesome. And so that's what brought settlers to our lands, and they're still there. They keep hanging out. And my family, you would have to fly in to that community. And the government of Canada, for whatever reason, put my family in with Lac Seul, which is by Sioux Lookout, but really my family's from Pekanjika. Obviously, I have a white father who shall not be named. My name in Anishinaabe is Winterfire. That's how you say it in English. I have found some people have not been around a winter fire. Is anyone here who's not had a bonfire in the winter? Oh, yeah. You're from Australia. That's right. And okay, Where are you from? Oh, India. Okay. So winter fires are super special because it's very cold and you get that crunchy snow. And I can tell by people's reactions, it usually evokes really good memories for some reason, even though if you're too close, you'll get a burn and a little spark that leaves these perfect little holes in your jacket. Or it melts your runners. I've had that happen. So the backside of you though is freezing. So we do this constant rotation of our bodies. So there's a technique to being close but not too close. Also tending a fire so that it's not too big but it doesn't fizzle out. So that's a huge responsibility because if you know me, I can be very sharp. I can be very strong. I have very strong feelings about my topic. I'm probably most known for my work on evacuation for birth, traveling for birth. In fact, one of my committee members is here. Love her. So I do have strong feelings about some of the things I'm going to say. And this is, I'm again so surprised at the things I'm not hearing today. And I'm not hearing about white supremacy. I'm not hearing about patriarchy that is explicitly linked with white supremacy. I'm not hearing how Donald Trump is the epitome, the embodiment of white manhood. Of course, he's not ill. He is the pinnacle. So I just, and maybe we all know this, but I think it's important to say it. This is not fun for me. It's difficult to tell you some of these things. You probably know them, but seeing them all together hits a little different. So I'm vulnerable. And I just want you to know, so I'm sort of like this water that's crashing down sometimes in this little waterfall, which I know they're everywhere in the world. And I'm trying to not let that become part of who I am, that constant rage. Because for those of you who knew me as younger, it was, and I have to be careful with that energy now. So here we go, Canada, with all of its healthcare systems. And who was that lovely lawyer talking about the Canada Health Act and it being about fiscal transfers? She's still here. Oh, I really love that. Thank you. I wish. So this is like a idea that people say, oh, well, we can't do that. We have the Canada Health Act. I'm like, you have no idea what you're talking about. I know probably less, in fact, but it doesn't apply to the territories, and it certainly does not apply to First Nations on reserve, those transfer payments. Probably it doesn't apply to comprehensive land agreements or modern treaties such as Nunavut or Nunavik. So Canada was built on colonialism, white supremacy, misogyny, patriarchy, Christianity, and this one is really hard for people to come to terms with. And I put it in here though carefully because it is hard to come to terms with how Christianity has committed and been part of genocide, and not just genocide of one nation, but of many nations, and the ongoing attempts, systemic injustice and oppression that continue. So this is today. Nothing has changed. Perhaps it looks a little bit differently. But how many of you have ever had an Indigenous professor? Oh, a few. I love this. I've never had an Indigenous professor, and I've been in university for 16 years. So Canada was built on the genocide of Indigenous peoples. And I just was on the Facebook, and one of my friends, Evelyn, just shared that St. Anne's now is going to be searched for mass graves of children. And I really feel strongly that Indigenous midwifery disrupts this genocide. Oh, yucky things now. I'm just going to count how many yucky slides I have. I have 5, I'm sorry. Stealing our children, destroying our governance systems. This one's really interesting because it's not well studied, but how the potlatch was interrupted, and that was a major governance system. I'm just studying that now through a diploma at Carleton in philanthropy and nonprofit leadership. And I didn't realize how gendered roles and sexualities played in potlatch. I really appreciate this nurse up here nodding, just so you know. Thank you. Like working for me. Imposing patrilineal family relations. So my family's actually matrifocal. but imposing patrilineally really is harmful to people, killing our dogs. So this is really interesting because the RCMP, in fact, Canada said, we never did that. And Inuit has been saying this. And then recently the RCMP has formally apologized for this. Because of course, Inuit were moved far north for the sake of becoming securitizing actors for this country. So gross. Again, enfranchisement, confinement via the reserve system, burning our knowledge systems, perpetuating this idea that Indigenous people were only oral, in fact, written text as well, but that was burnt, as if having, like, of course we have to write it down, and jail those of us who practice our ways, label us traditional and static. So when I hear people talking about their land acknowledgements in the traditional territories, you are contributing to the historicization of Indigenous people. I'm like right here, like, can't you see me? And you can't see Indigenous people. And it's easy for you to not, yet I have to see you all the time. I have to live in a world of whiteness, and I don't like it. Violently imposing Christianity, making our ways of health and wellness illegal, like Indigenous midwives, Indigenous care providers, Indigenous medicines. Oh, but at the same time, earning money off of it. So taking our knowledge and medicines and turning it into a pharmaceutical. Conducted medical experiments. My own stepfather was part of the nutrition experiments at his residential school. That's actually really hard to know. It's also really hard for me because he was a Christian, and my brain just can't wrap my brain around that. And so I know we all live with incongruencies, but that one I don't understand. But that's okay. I don't need to know everything. This one, my friend actually went into the electric chair as a child when she was 6 years old at her Indian residential school. In fact, the last Indian residential school, my cousin went to it. So stealing our land, think about all the tax dollars people pay for these properties. The university, all of this goes to the city. And yet they stand there and talk about the unceded territories. I'm like, you are just so incongruent. Like everything next out of your mouth, I don't believe, which is why I tell you who I am. Stealing our land, forced and enforced relocations. Ugh, thanks, Sarah. I see you. You know this one. The residential school is the principal feature of the policy known as aggressive civilization. Indian culture is a contradiction of terms. They are uncivilized. The aim of education is to destroy the Indian. I want to get rid of the Indian problem. Our objective is to continue until there's not an Indian that has not been absorbed into the body politic, and there's no Indian question and no Indian department. That sort of sounds like today, right? Same in 1969 with Chrétien and Trudeau. Oh, here we go again. Breaking treaties, medical cost, obstetric violence. We've heard about all this. I would love to say registered midwives are exempt from these conversations, but they were instrumental in the eradication of Indigenous midwives. Colonial challenges. I've also heard people call this a colonial hangover. So where do Indigenous midwives reside in federal policy? Just kind of through exceptional funding. Right now, the current popular one is the AIR funding. Does anyone here hold AIR funding besides me? Anti-Indigenous racism funding. We're not named in Treasury Board, so you can't hire us. This is the verbiage that I get. But vets, we can hire vets. Yay, us. Legislation, only Ontario specifically mentions Aboriginal midwifery. They're using the constitutional language. In Nunavik, which is a comprehensive land agreement, Inuit midwives do need to meet the Quebec standards, even if they're trained outside of the Western medical, like midwifery programs. So I wonder, why do Indigenous midwives need exception or exemption legislation at all? And how is the self-determination of Indigenous midwifery impacted by pretendians? So I was in a little meeting and we were talking about who we are, and there was a new person, a student, Indigenous student. I said, oh, I usually know everybody. Who are you? And it turns out she's Indigenous because her family found a song in the attic that might be then her claim to indigeneity. I'm not even joking. Remembering that these are healthcare professionals who are working under exemption legislation to provide clinical care. Dangerous. Clinical or cultural care. Like, it's enraging, at least to me. And then we're thinking about the UN DRIP Act, and, we have the action plan and what we've learned. Such good times writing reports. Then we have the CMA apology. Has anyone listened to that? Really? Okay. One hand. Okay, good. Oh, one person's watched it. Good. Okay, we're saved. So, how much does it cost as a care provider to totally commit genocide and forcibly sterilize someone? It will cost you, if you're a physician, $20,000, which doesn't go to the person that you've completely destroyed their life. It actually goes to the college for their fees. So this person, who I'm going to name because it's public knowledge, and it's actually one of the very few physicians that we know has been named as committing forced or coercive sterilization. Andrew Kutsak. Someone else say his name. It makes me sick. There we go. Can't stand him. Now look at his specialties according to the UBC website. Preserving physiological birth, respecting women's autonomy, avoiding an unnecessary, like, do you see the discrepancy? This is such a good example because he was thought to be some midwifery champion while he was in the Northwest Territories. Meaning he was controlling all of the process. And like, oh, what the ethics of informed choice, that's his specialty now. Love that. We should say his name. So this is when I just feel like exploding. I'm so angry. And I don't understand why no one else is. And I know you can't, again, remembering the winter fire, you can't always be angry. And I deserve to live a beautiful life, hanging out with my friends, doing beadwork, walking around, meeting new people. I deserve that. This is astounding to me because I feel like, does anyone care? And Indigenous midwifery is more than human rights for Indigenous peoples. It's the practice of our roles and responsibilities. It's who we are. Yes, I know. So this is, again, back to the very beginning slide about Indigenous midwifery as an Indigenous community longing for itself. I have one more slide, but let's forget that. Wait, watch.
Thank you very much for that, Dr. Lawford, and reminding us that as we talk about access justice in Canada, that it's important to center the realities of people who've lost access to themselves, their histories, and their communities. And I think we can all agree that in the practice of Indigenous midwifery can certainly hold the heart to the restorative experiences. So thank you for that. So now we move on to Dr. Christabelle Sethna, full professor at the Institute of Feminist and Gender Studies here at the University of Ottawa. And we will hear Birth Control, a Public-Private History.
Great, thank you. Can everyone hear me? Yes, okay, good. So I'd like to thank Dr. Vanessa Grubin and her team for making this conference possible. I'm really happy to be here today. Most of my work centers on combination of history and travel and journeys related to abortion services. But every now and then I return to my first loves, which are venereal disease and birth control. That was supposed to be funny. I don't really love venereal disease. So because of the move toward pharmacare, Vanessa encouraged me to return to one of my first loves, birth control. And so that's what I'm going to be talking about here today. So many believe that the decision to use a birth control method, medication, or device belongs solely to the realm of our private lives. And yet such intimate decision-making is freighted with history and influenced by larger sociocultural and political contexts that have given rise to serious social inequities, so serious that in some instances that decision-making power does not reside in the hands of the individual. Our most intimate moments, whether we realize it or not, continue to be shaped by a host of public forces that call into question notions like individual privacy, autonomy, and liberty. So I want to do a sweep of birth control history in Canada. Some of you might already know some of this, to consider it more seriously given the recent passage of the Pharmacare Act and coverage for contraceptives. So there's plenty of evidence to show that individuals have always tried to prevent unintended pregnancies using ointments or herbal potions and even spiritual practices in addition to homemade barrier methods. Condoms have been traced back centuries, made from animal intestines or linen or silk. They were intended to prevent the spread of venereal disease. And it was not until the late 1800s with the development of rubber manufacturing and in the 1920s, the use of latex that made condoms an effective reversible male-dependent contraceptive. Reversible female-dependent contraceptives included the diaphragm and the cervical cap, and both were mass-produced along with spermicide jellies. Moved by fears over immigration and the presumed threat of race suicide, meaning the decline of the white race, the federal government in Canada criminalized not only abortion in the late 1860s, but also the sale, advertisement, and dissemination of information about contraceptives and abortifacients in 1892. Nevertheless, a brisk public trade in contraceptives and abortifacients of varying efficacy materialized, even when they tended to be stigmatized because of their association with illegality and sex work and venereal disease. In the 1920s, influenced by American feminist Margaret Sanger, who coined the term birth control, meaning the use of devices, medications, and methods to prevent conception, a small birth control movement emerged in Canada, and it helped make contraceptives a respectable option for married women who wished to lengthen the intervals between the births of their children. However, birth control activists also anchored the appeal of contraception in the rhetoric of eugenics. Only mentally, physically, and morally fit parents should make healthy babies for the nation. Then, as now, abortion and sterilization fit uncomfortably into birth control narratives. Traditionally used as a solution to an unintended pregnancy after birth control efforts failed, abortion was driven underground. Global interest in eugenics led to coercive sterilization practices in asylums and institutions, and sterilization laws passed in Alberta in 1928 and in British Columbia in 1933 ended up targeting poor, disabled, Indigenous, and immigrant individuals. In the 1950s, Margaret Sanger's quest to find an effective, easy-to-use universal contraceptive resulted in the development of the birth control pill in 1953. And the pill, a reversible female-dependent oral contraceptive, is a concoction of the hormones progesterone and estrogen and works by inhibiting ovulation. Its test history, beginning with animals and moving toward male and female mental patients, and then on to women in Haiti and Puerto Rico who were unaware that they were swallowing an experimental drug, remains a matter of controversy. The arrival of the pill on the contraceptive scene and its very lucrative aspects led to the subsequent development of a range of reversible female-dependent hormonal contraceptives, such as implants and injections, carrying their own similar uncomfortable histories. And in comparison to other contraceptives available at the time, was very effective. So it was approved by the Health Protection Branch in Canada in 1961 as a prescription contraceptive. So the pill was touted as a respectable option that would reduce abortion rates amongst married women. And doctors cautioned against prescribing the pill to single women out of concern that it would unleash a wave of sexual immorality. And the appeal of the pill was also anchored in Cold War anxieties over population growth in Asia and Africa. Very quickly, the pill was celebrated as a means of preventing geopolitical disaster. It became part of a birth control arsenal, including voluntary and coercive sterilization, that an international network of family planning organizations in the global north and the global south supported in the name of women's reproductive rights and population control. The pill pushed many to see Canada's birth control laws as archaic. They demanded legal reforms, including liberalizing abortion, something that was fiercely resisted in many quarters. However, the consequences of an unwanted pregnancy were acknowledged to be serious, and fears came to focus on young, single, white, middle-class women facing stigma and interruption or cessation of educational pathways, or a derailment of employment prospects, as well as the health risks and possible death from illegal abortion. In 1969, the federal government passed an omnibus bill intended to modernize the criminal code. And two of the key reforms were decriminalizing contraception and legalizing abortion. But prescription contraceptives, including the pill, were not permitted to be advertised, and single women still had difficulty accessing pill prescriptions. Some doctors refused to provide prescriptions because they confused the pill with abortifacients, while others were morally against sexual relations before marriage. The pill quickly became notorious for several reasons, in addition to its test history, its association with population control, and evidence of negative side effects and possibly even deaths in the early high-dose version of the pill. One of the other reasons why the pill became controversial is that although it encouraged the belief in a woman's right to contraception, it also enabled the conviction that women bear near total responsibility for an unintended pregnancy. Another reason was that the pill, highly effective, and as I said before, very lucrative, stymied the development of a reversible male-dependent contraceptive. Furthermore, the pill never lived up to the hyped-up hope that it would reduce abortion rates, even when it began to be used extensively by young single women. In fact, abortion rates increased rapidly after the 1969 criminal code reforms, although many women found accessing a timely legal abortion impossible. The abortion law required a hospital-based therapeutic abortion committee to determine on a case-by-case basis whether continuing the pregnancy threatened the life or health of the woman. And if a woman's request for an abortion reached the committee, she could be barraged with personal questions such as the number of years of schooling, her type of job, her length of marriage, the forms of birth control she used, and her reasons for not wanting a child. Women who stated they used birth control but still got pregnant had a better chance of being granted an abortion than women who did not or did not know how to use birth control because they appeared irresponsible. Over the next 2 decades, feminist groups and organizations developed a women's health movement, encouraged women to learn about their bodies as a form of political empowerment, raised awareness of contraceptive safety, spoke out against reproductive abuses, especially amongst poor and racialized women, called for comprehensive sex education for youth, fought for abortion law repeal, referred women to abortion providers inside and outside Canada, set up abortion clinics and women's centers that challenged the patriarchal slant of the law, the medical profession, and the pharmaceutical industry, and raised money to defend Dr. Henry Morgentaler, who defied the abortion law by providing safe and affordable abortions in his clinic without the approval of therapeutic abortion committees and hospitals. And the abortion law was finally overturned in 1988 in the significant ruling R.V. Morgentaler. However, this judicial victory was tempered by the flourishing of the anti-abortion movement and the spread of anti-abortion violence and harassment. Abortion access, including medication abortion, remains uneven across the country, particularly in northern, rural, and eastern Canada. This sweep of the turbulent history of birth control brings me to the current day and the Pharmacare Act, which received royal assent this October. The Act needs some caveats when it comes to coverage of contraceptives. First, Pharmacare coverage now extends to 49 brands of birth control pills, 13 brands of the copper IUD, 2 hormonal-based IUDs, 1 contraceptive injection, 1 hormonal implant, 1 hormonal vaginal ring, and 3 vaginal emergency contraceptives, one of which is available over the counter. This list reinforces the focus on female-dependent forms of reversible birth control. And this kind of coverage should not discourage the development of a safe and effective reversible male-dependent contraceptive. Second, by providing coverage for prescription-only contraceptives and mainly prescription-only emergency contraception, it is important that access to such prescriptions does not become onerous given national doctor shortages and long wait times to see a doctor, especially in remote communities. The fact that registered nurse practitioners in some provinces like Ontario can now prescribe contraceptives may alleviate the issue. Third, I'd like to see Pharmacare coverage extended to all contraceptives, including non-hormonal and over-the-counter versions, to expand the range of contraceptive choices, especially for those who can't tolerate hormone-based versions. As well, many contraceptives do not offer safeguards against STIs, but condoms do. Fourth, governments and regulatory bodies need to ensure that patients are protected in the event that medical professionals refuse to prescribe or dispense contraceptives or emergency contraception on the grounds of conscientious objection. Protection must also extend to the confidentiality of all record keeping. Fifth, contraceptive coverage in the case of long-acting hormonal contraceptives must not be deployed coercively against underprivileged and racialized populations as a form of reversible sterilization. Last but not least, and this is for all the lawyers in the room, it is important to prepare for the fallout of changes to the US reproductive landscape since the Dobbs decision in 2022. The subsequent passage of abortion bans in 13 US states, court challenges to medication abortion, and the recent election of Donald Trump to another presidential term presage the possibility of a national abortion ban and restrictions on birth control as part of the Republican Party's pro-natalist agenda. These developments might embolden Canadian politicians and activists with similar beliefs. They may also lead Americans to cross the Canadian border to access abortion and birth control services. And such cross-border traffic, which is what I've been studying historically, will not only pressure the Canadian reproductive healthcare sector, it will also trigger international complications related to the confidentiality of medical records, geolocation, financial transactions, and the tracking of mail service. These scenarios must not be dismissed as a work of dystopian fiction, but as a realistic consequence of draconian legislation, ubiquitous digital connectivity, and the breaching of data privacy, whether legal or illegal. Birth control history, as this presentation shows, is already a cautionary tale. Thank you so much.
Thank you, Dr. Sethna. And our final presentation, Dr. Holly McKenzie, Assistant Professor in the School of Public Health at the University of Saskatchewan and Adjunct Professor in the Department of Gender, Religion, and Critical Studies at the University of Regina, will present Involuntary Treatment, Carcerality, and Reproductive Autonomy.
Oh, it's back. It's back. Okay, hi. So yeah, I'm Holly. I work with Indigenous and non-Indigenous communities to advance reproductive justice and health in research. I ended up in the School of Public Health, but I'm interdisciplinary. And this work really comes from from a project that Alana Katapan and I are working on with women who have stayed at Sanctum 1.5, which is a prenatal postnatal home for pregnant people and people who just gave birth in Saskatoon, Saskatchewan, who are at risk of HIV and are at risk of the child welfare forcibly removing their infant. And through the work that we've been doing there with women where there's a lot of interconnected, ongoing legacies of intergenerational forced removal of children through the residential schools, 60 Scoop, child welfare system recently, substance use, violence, and trauma, and more than 80% of the women who access that prenatal postnatal home are Indigenous. And so I'm so thankful for their stories about how the punitive systems cause harm for really, and all of the other Indigenous colleagues and friends that I work with who have really taught me to look to what the so-called justice system with this critical eye, and to also that there are other ways to do things. So since 2023, and since I am not a law scholar and I'm talking about law, I'm really excited to hear what you all have to say. So since 2023, provincial governments in Alberta, New Brunswick, and British Columbia have announced plans to establish involuntary treatment legislation to target people who use substances. So in Alberta, the proposal from the UCP government has to, quote, allow a family member, doctor, psychologist, or police officer to petition a non-criminal judge to issue a treatment order. This would be similar to existing involuntary treatment laws related to mental health, where a person in distress or who may cause harm to others, and to a law that allows parents or guardians to petition the courts to have the youth put in treatment for substance use. So in New Brunswick, the government who initially proposed this has now been voted out of office. Go New Brunswick. But British Columbia, whose government was recently reelected, has also introduced plans to do similarly. And there are a lot of critiques about this kind of legislation. Oh, yeah, I should move the things. Oh, right. We did this last time we presented this, we did this too. We were like, she made this beautiful thing with like map with all of the provinces so people can see. And then I forgot to do it. Okay, so there have been a lot of critiques of this kind of legislation. People are concerned that there's no evidence that suggests that involuntary treatment is effective. Forcing people into treatment is often ineffective and actually makes them more likely to overdose when released, right? Forcing people into unwanted treatment can also alienate them from health and social services when they do want to seek substance use support. Critics have also raised concerns about what happens when people are released from mandatory treatment without housing or other supports. Others still view that mandating drug treatment as undue and unjustified expansion of the carceral system, using healthcare dollars to effectively criminalize people who use drugs without enacting criminal law. Okay. Oh, I think yeah, see, okay. In this paper, though, what we're concerned about is this shift to what this shift to mandatory treatment might mean for pregnant people, and its implications for reproductive autonomy. Proposals for legislation that would force people using drugs into involuntary care has not yet explicitly included any discussion about pregnant people. But given the desire that they've already articulated to mandate care for people deemed to be a harm to themselves or others, it's entirely possible that pregnant people who use drugs will be a target for involuntary treatment. Involuntary treatment may be a new way to control the bodies and actions of pregnant people who use drugs to advance concerns about fetal rights under the guise of addressing substance use or addiction. So in the next few minutes, and after a few notes about the history of this kind of legislation in Canada and elsewhere, we're going to examine what the potential implications of this legislation might be for pregnant people. We're going to talk about how it pulls people out of their communities, deters them from healthcare, and works to shore up the surveillance of pregnant bodies in the name of fetal rights. Okay. So debates over mandatory treatment in Canada and elsewhere have a long history, and particularly when it might apply to pregnant women. Canadian law and public policy, particularly following the Morgentaler case, have long taken the position that the state cannot control pregnant people's behaviors, even in situations where the health of the fetus may be at risk. This approach also builds on the 1988 landmark case, Winnipeg Child and Family Services versus DFG, in which the Winnipeg Child and Family Services sought a court order to detain a pregnant First Nations woman who sniffed glue during pregnancy, citing potential neurological damage to the fetus. The Supreme Court of Canada found in its majority decision that this was a matter for legislature, and that conceiving of a fetus and a pregnant woman as separate persons would infringe on women's bodily autonomy. So this case and the surveillance of DFG's pregnancy is part of the history of surveillance of pregnancy that's occurred since always. When women and mothers do not act in ways that are entirely center the needs of the fetus, infant, and or child, they're cast as bad mothers in ways that can pit the needs of women against their own pregnancies and children. This surveillance is particularly acute for people who experience other types of precarity and marginality, Indigenous women, people of color, people living in economic precarity, and so on, and definitely for people who use drugs or alcohol. The position folks are in is impossible due to Euro-Western presumptions about what makes a good mother in the first place. And although I don't have time to talk about it here, these presumptions too have exacerbated this moral panic and media hysteria about so-called crack babies in the 1980s and 90s, and the legacies of the rhetoric about the, quote, epidemic of fetal alcohol spectrum disorder in Indigenous communities in the 1990s. And if you have not looked at this work about the latter, I really suggest you look at Amy Salmon's work, Caroline Tate's work. They have written about this much better than I can talk about it in a couple minutes. So, okay, see, again. So, the first major concern we have is about how involuntary treatment removes people from their communities and families. For pregnant people and parents, communities of support are critical, not only for their own survival, but for the survival of children. The Canadian state, via provincial child welfare services, already engages in some measure of coerced drug treatment for pregnant people and parents. For example, despite the elimination of birth alerts in most provinces, pregnant people who use drugs are often flagged by healthcare providers to trigger state involvement at birth. And for many, this begins a cycle of jumping through all sorts of hoops with health and social services and treatment in order to regain the custody of their children. Involuntary treatment will likely expand this approach and be applied to require people who use drugs to be confined to treatment against their will. And this is going to alert the child welfare authorities to their substance use. And it will likely, first of all, if they have the custody of their children when they are committed to involuntary treatment, unless there's kin to care for them at the time, their children will be removed and put into care. Also, it will likely mean that after they have the child, that child welfare will be involved and likely will remove their children and then put them into this hoop jumping place where they are doing all sorts of various steps to prove that they are children who should have custody of their children. As Ms. Lombard talked about, the onus is in the wrong place again. So, yeah. Okay, yeah, we're good. Thank you. See you, Sarah. Sorry. I know I feel like I'm oriented a different way, so I was worried I was going to miss you. Okay, so while involuntary treatment legislation has been framed as increasing access to care to those who need it, is likely that these laws will undermine access by reinforcing stigma about substance use. This stigma is intensified for pregnant people whose substance use is often interpreted by social services and the justice system as bad mothering, and triggers additional surveillance, as we mentioned about the child welfare and health care providers above. So this additional scrutiny can deter people from seeking healthcare services, including prenatal and postnatal care, and contributes to this long and understandable chronic mistrust of healthcare providers. And there's much more effective ways to engage people in relevant voluntary services, including making them more available and accessible, reducing wait lists, and so on. And this is not new. The Status of Women report after the DFG case that was led by Ruttman talks about the need for culturally safe services that are more women and family centered. Like, this has been known for a long time, right? And it's likely that the introduction of involuntary treatment legislation will likely undermine rather than increase access to services for pregnant people using substances. And this is really important because a lot of pregnant people do want to stop using substances for the health of themselves and their future children, the health of their children that they have now. But legislation and the fear of the material role of the carceral state within these decisions for health are likely going to drive them away from the very services they might actually want to access. The move towards mandatory treatment for people who use substances is also occurring at a time when fetal rights discourse is on the rise. The idea of fetal rights, as I think most of you know, is an anti-abortion strategy that seeks to accord human rights to a fetus at the time of conception. So in the paper that we're writing together, we talk about how this has been operationalized in the United States and how women have been prosecuted for child endangerment or neglect for using substances in pregnancy, as well as the law in Wisconsin that allows forcible confinement of pregnant people who use drugs. In Canada, though, this isn't the case. As we talked about before, since the Morgentaler decision and the DFG case, the federal government has stayed away from trying to explicitly govern pregnant people's behaviors, and certainly not through criminal law. There are public health campaigns and such, and there's been these independent member bills that have been introduced but really have not gone very far. But proposals for mandatory treatment in Canada build on a long history of similar treatment interventions in the United States. And provincial governments, while they can't change criminal law to criminalize substance use in pregnancy, but using this expanded mental health legislation, they can require people harming themselves or others to be committed to treatment. So insofar as the actions and bodies of pregnant people are highly surveilled, implementation of these laws could and may end up targeting pregnant people and confining them to treatment as a matter of course. It's an insidious approach to effectively criminalizing behaviors in pregnancy, but one that could emerge because of the hypervisibility of the pregnant body. So, as we said before, the implications of involuntary treatment for pregnant people are significant, including removing people from their communities, creating mistrust with healthcare providers, but also the targeting of pregnant people for involuntary care could be a means to sidestep the long history of non-intervention in pregnancy advanced by Canadian legislation and jurisprudence in the names of fetal protection. So in this paper, we are considering what the shift to involuntary treatment might mean for pregnant people and parents in reproductive autonomy. I think it's this one. Yeah, there we go. It's fine. Oh, wait, no. See, I missed a whole bunch of slides. Okay, that's fine. Please tell the story. Okay. So as these provinces move towards involuntary treatment, which is in conflict with bioethics principles of autonomy and informed consent, and assume that people who use substances are not able to make decisions. And thus the state should step in, right? And we're concerned about how this is going to be applied to pregnant people. And it's another way to also expand the criminalization of substance use and to enmesh the health and justice system's responses to substance use at a time when there's this call for decriminalization. And these moves to involuntary treatment are also problematic when you consider the lack of available voluntary substance use treatment and services. We work as I said, with women who have used substances during pregnancy in Saskatchewan, and they have shared numerous stories about not being able to get into treatment centers for weeks or months after they've made the decision that they want to address their substance use. So overall, though we are paying attention to and concerned about how involuntary treatment is likely to be applied in ways that control the bodies and behaviors of pregnant people who use substances, as well as to gain ground in the fetal rights conversation in Canada through scapegoating pregnant people who are constructed as bad mothers because of their substance use. Thank you, and sorry for going 30 seconds over. I blame the slides.
See, I had this whole thing. It was so beautiful. Thank you to our lively panel discussion. So as some of you in the audience might be making your way to the microphone, if you have questions for our panel, I will perhaps add my own reflections. We've taken a journey considering that Canada is, as always, fraught by its colonial history, and which has stripped access of our Indigenous peoples' rights to their traditions, to their knowledge keepers, and to their way of life, something that perhaps Indigenous midwifery could go a long way to restoring. We've talked about the history of, I'm trying to think genealogically, so we've talked about the history of the birth control pill, where access, in fact, was in part denied, perhaps due to misogyny and fear of sexual liberation. Geography will always figure into Canada's story, and although geography presents a significant barrier to various services and our limited healthcare providers, at the same time, perhaps technology such as mifepristone can help open up some of these geographies, as we've seen with the mailing out of mifepristone and abortificants in the US from blue states to red states. And finally, as was just mentioned, and I guess I'll start us off with a question, that we've focused necessarily on autonomy and focusing and centering the pregnant person. But if we think about the last discussion of substance abuse, often this is a somewhat comorbidity with partners, as can be in some cases the cause or reason for the incarceration. And once again, we're looking at the outcome of the criminalizing the behavior of substance abuse rather than perhaps effective deterrence and treatments, which may be education, which may be enhanced engagement in education in communities, but also access to treatment. But what, if anything, is the role for partners? I'm almost loath to bring this up, as our keynote speaker addressed as well. It's kind of scary to think of partners, but partners of all genders who may contribute to the genesis of substance abuse, and also might further that substance abuse might impact the quality of the pregnancy.
Well, it's very interesting that you bring that up, because how we have organized treatment, like, so I'm going to, because this is work that is really looking more at policy and services and is coming from what people have shared with us, but existing existing literature that's out there that we know of is largely treatment, and access to treatment is for individuals, right? And so there's very limited family treatment options. So people are in situations where, in order to access treatment, they have to leave their children, they have to leave their partner. Their partner may go to another treatment facility. And so I think that, and there are some specific models of family treatment. I know of 2 in our province. Saskatchewan is a small province. So I know about 6 to 7 treatment facilities. substance use treatment facilities. One is specific to crystal meth and is in the very southeast corner of the province, which is 2 hours away from the nearest city. So very, very limited treatment resources. So actually having 2 family treatment at this point is a huge improvement over what we used to have. So I think that a lot of times there is just not that recognition that this person is not an individual, and that comes from the long history within substance use treatment that was really based on this AA model that was very abstinence-based, that was very much masculine-based. And the fact that we're just still really moving to what does women and family-centered treatment look like? What does it mean to understand relapse as part of recovery of substance use? What does it mean to engage harm reduction? Like, these are all questions we're still working through. So I don't feel like I answered your question, but I answered a question.
Do we have questions from the audience? I think we do. Here we go.
Hi, can you hear me?
Yeah.
Thank you so much. This wonderful panel. I really appreciated all your topics and what you shared with us. I'm just wanting to ask a bit about strategies. I think one thing we should observe in BC, I'm from BC, is that there was complete capitulation and reversal of policy from a progressive position to a conservative position in foreseeing the election coming forward. So that's a real warning for every jurisdiction that the left fears the right will win, and therefore they just adopt the right-wing policy. Not just about that, but I'm wondering what you see as kind of giving you hope, or what you think is a good leverage tool. I really appreciated, I have a cheat list here of your names. Dr. Sethna's list of like recommendations. I wish I could get a hold of that actually, but other people as well. Like I appreciated the earlier speaker saying that, you know, we need to do everything to prevent the coercive sterilization, but what do you think are some hopeful tools? And more specifically, we haven't, as a country, signed the Maternity Protection Convention of the year 2000, and I'm sure you were aware of that. I was at a presentation with someone from UNICEF, really brought that to my attention. Maybe that's a tool. Also, in BC, we have the First Nations Health Authority, and for Karen Lawford, pardon me, Dr. Lawford, I'm wondering if you think, or have you seen that the fact that there's a First Nations Health Authority, has that enabled midwifery in BC more than in other places, if that's a fair question?
No, but the question. Okay. Do you want me to start?
Yes.
Why don't I start? Okay. So, so I think where we are in this is really, it was a lot of rage writing. Mostly me bugging Alana Catapan and being like, I'm really mad about this and I see this happening. And then she rage wrote with me. But so there's that aspect of it, which I think is probably in a healthy way to get it out. But the desire to also want to communicate this to various audiences so that we can dispel this misconception that something like involuntary treatment legislation is going to increase access and that it's going to improve the health and well-being of people. We know that it is not, and that what actually we need more available services. And this is a way that actually I anticipate, or I'm speculating that the governments are like blaming unhoused people and saying that they are unhoused because of their substance use, and this involuntary treatment is going to do something about that, when we know there's not enough treatment beds for people who want to access treatment. And so really getting that information out there, I think, to multiple audiences is something that we're trying to do with this work. And I think so that's a strategy for trying to intervene in this. But yeah, and there's a similar thing actually happening in Saskatchewan right now with these complex care centers where people are being picked up on the street because they're a danger to themselves or others, and they are being placed in there. And no one really knows how any of that works. right? Because it's a private company that's been brought in to do that. So there's a lot of these different places where this is happening. And so I think the more we know about it, the more we can mobilize and address the misunderstanding, the misconceptions out there, and that we can also, if this legislation is rolled out, really attend to how is this being applied to pregnant people and fighting back on that level. So that's my thoughts.
Hi. Okay. Things that are giving me hope are few and far between. But I will say, first off, I think we heard in a couple of the presentations on this panel and earlier today, we know how to do these things. We can learn a lot from history. We can learn a lot about what is happening in the present. We know things that work, and we should hold on to those and see what we can bring from them, going forward. I also think in my work, especially, what has been astounding is the leverage of a politician who is loud and annoying and is sort of just there beating the same drum over and over again about whatever the issue is. I went through many correspondences of William Lyon Mackenzie King and Robert Borden. It is wild what people write to them about and that then get preserved in the archives forever. But that's, I think, a little bit what we need is we need people being loud, being annoying, and really getting out there. The last thing I will say is a few weeks ago, I was at the Canadian conference for the National Abortion Federation, and we had a discussion about political action, political advocacy, and so on. And one of the things that I think I'd like to maybe throw out to this room is the idea of people, again, getting loud, writing op-eds, rallying their communities in whatever ways they can. And particularly for people who are not academics. Academics are easy to brush off, right? We're just the academic lefties that are hanging out in our ivory tower. But if you happen to know people who are doctors, lawyers, nurses, et cetera, midwives, all of those professions that are harder for people to brush off as just being disconnected from reality, get them being loud and writing the op-eds and getting out there. And I think, we keep each other safe and we keep each other going. And that's what I'm hanging on to.
I'm tired of the word hope. I'm tired of words like joy and words like compassion. We need to take action. We need to organize. And we need to be pragmatic and practical about what we do. And some of what I discussed in my short list of caveats to the pharmacare plan is the pharmacare program is about planning in the given the possibility that things might go wrong. I think trying to always strive for hope, quite frankly, is meaningless when what we really need to do is have a game plan and not be caught unawares. And then suddenly turning to hope and joy and compassion as though these three, mantras will help us get out of a very serious crisis that we're going to be facing. Canada is, whether we like it or not, you mentioned geography, we are imprisoned by geography. We are attached to the United States. And whatever happens in the United States eventually flows northward. We're already starting to see discussions about immigration in Canada, and we can expect similar rhetoric to what was used in the United States to rally crowds, to the side of Donald Trump, to happen here in Canada. Similar discussions I anticipate similar discussions about reproduction. And also we need to face that we are experiencing in North America and Western Europe a population decline. This is a demographic fact. This population decline is stoking a lot of the white supremacy that we are hearing about in political speeches. So we need to anticipate all of this. We need to plan, we need to game plan, we need to strategize, and we need to stop talking about hope. Okay.
I just wanted to echo everything my co-panelists have said, but the one thing that I do also think is really critically important is gathering data. Like if we didn't do this work, if we didn't know what the picture really looks like, we don't know what the problem is. If we have to have something to measure progress or the lack thereof against. And so I think that it's really important to acknowledge that Canada is not very good at data, as a couple of us have talked about, and really start to work on that project too.